this is...
Welcome to the meeting. Just remind members, please, that the meetings are held in public session. Please switch off mobile phones, as they will interfere with the recording. Apologies. Anybody? Any apologies? Okay. A number of items under Chair's business. We've just received or finished a session with Daniel Greenberg in relation to the data processing bill. I think it would be useful following that conversation that we sought an update, another evidence session with the department in relation to the bill going forward. There was a number of items that we discussed previously, so I think it would be important if we could get members' agreement to do that. Agreed? Agreed. Secondly, just in terms of our recent visit to the Royal and to the Gum Clinic, seeking agreement, members, that we would write to the department for clarification of what priority, if any, has been given to the gum services in the 2015-16 commissioning plan. Also, members, the rationale for separate commissioning arrangements for different elements of sexual health services, namely HIV and gum, and whether consideration has been given to the development of an integrated commissioning plan, and details of what consideration has been given to the appropriate relocation of the clinic. I think it was very apparent the very valuable and vital role that staff carry out on a daily basis there, and in very difficult working environment. So if members are in agreement, we would seek that clarification information update from the department. Also, members, in terms of the ministerial group on public health, again seeking your agreement to write to the department to get an update on the work of the ministerial group, and including details of the terms of reference and how often it has met and intends to meet. Also, members, you will be aware that the Audit Office General Report on Health and Social Care sector has been in the public domain this week for the period 2012 to 13 and 2013 to 14. Just advising members that the Public Accounts Committee has a statutory function, obviously, to consider the audit reports, and has to be allowed, I suppose, to complete its work to avoid any confusion. But I am seeking agreement here that we would write to the Public Accounts Committee to express the committee's interest in this topic. There's a number of key headline pieces coming from that, and to be asked to be informed of any outcome when it's appropriate. Also, members, today there was the launch of the Human Rights Report inquiry into emergency care, seeking agreement, members, that we would write to the department for a ministerial departmental view on the findings of the report. Are members in agreement with that?
Chair, just a comment on the report earlier this week in relation to the waiting times, particularly for cancer. I mean, transforming your care is and has been the way forward, and prevention and that, you know, early detection is the name of the game there. And yet when I find are detected early, the service is not available, and you know that is really shocking, in my opinion, that people cannot have the attention that they need and deserve at that particular time. So if anything can come out of that, you know, we look forward to that.
Yeah, no, absolutely. I think there's a number of key headline points in that. The fact that 4 out of 5 of the trusts weren't able to meet their I suppose their deadlines, if you like, in terms of their savings plans, the cancer waiting times in relation to particularly breast cancer, and also the issues around procurement. So I think we're mindful we have to allow the Public Accounts Committee to do their piece of work, but certainly this committee has an interest in the outcomes coming out of that report and recommendations. There's a number of items, members, just in relation to the Forward Work Programme. The department has yet to give us any details or dates for the informal meeting with the new minister and myself and the deputy chair. So the committee staff will continue to try to get dates for that. Officials also from both the Safeguarding Board and the department will attend the committee on the 24th of June to brief members on the forthcoming report on the thematic review into child sexual exploitation. It's intended that the Safeguarding Board will speak first as the authors of the report, and the department will then provide its response to that. There's a number of concerns have been raised in correspondence from last week's stakeholder event, also in relation to the infrastructural support programme. The committee wrote to the department for an update on funding for the programme, and there was a response received this morning. There's a copy of the response on your tables. Just maybe suggesting if officials here want to update the committee on the, or if we may wish to write back, but maybe we want to get an update if people want to reflect on the letter that's come in today. Are members comfortable then that we would bring officials, invite officials to update the committee on the department's core funding at our meeting on the 10th of June?
Yep.
Members in agreement we do that. Okay. Item 3 is the draft minutes of the meeting on Wednesday the 13th of May, which are on page 5. Are members content with the minutes? Okay.
Great.
And item 4 is the review of workforce planning in the context of transforming your care. Just reminding members that the committee wrote to the 5 trusts in April to obtain more information about the work that they were undertaking in relation to workforce planning. All of the 5 trusts have now responded, and the responses are at page 18. The original letter that lists the requested information is also included at page 59 of your meeting pack. And there's a number of common key themes within the 5 responses, if I would just highlight a number of them. Members will know from previous evidence that there is a HR representative from each of the 5 trusts on the Regional Workforce Planning Group. However, this seems to be, in the trust definition, be a platform for the trust to request greater momentum and proactivity from education providers and training bodies to address skills gaps, and that was according to the Northern Health Trust. The onus of workforce planning seems to be with the trusts, and I suppose that's something that the committee should reflect on. And all are currently undertaking its own work into workforce modelling or workforce planning. Many are undertaking workforce planning training using the 6-step model by Skills for Health, which was a piece commissioned by the department. This, members may suggest that the trust have the same knowledge and information in relation to workforce planning, but doesn't necessarily mean that they're using the principles of that training when undertaking workforce planning. Also, the trusts seem to face the same challenges. Recruitment and retention of staff is a key issue coming from the responses, obviously within existing resources, and developing plans for service change while keeping the objectives of transforming your care. So there seems to be a clear pattern coming there that's coming through all of the evidence in relation to recruitment and retention. And to tackle the challenges, each trust seems to have its own internal groups and processes to ensure an appropriate supply of staff. So to advise members that the 5 trusts, as I said, are scheduled to brief the committee on our meeting on the 17th of June, so we can probe out some of those issues there. Members may wish to question trust officials obviously more thoroughly on that day in relation to their own workforce planning against the committee's terms of reference. Want to refer members to page 14 of your meeting folder for a briefing paper from Allied Health Professions Federation, and advising members that representatives from the Federation are here today to brief members on workforce planning in the context of transforming your care, and you're very welcome to the committee. We've Karen Middleton, Chief Executive of the Federation England, Rosalind Rogers, Education Representative on the board, and Andy McFarland, elected representative of College of Paramedics on the board. So again, you're very welcome. I'm going to hand over to yourselves to make your opening remarks, and we'll open it up to questions or comments.
Thank you very much indeed. We very much welcome both the invitation and the opportunity to speak this afternoon and to address your questions. The chair of the Allied Health Professions Federation, Kerry Clark, sends her apologies. She's in Scotland unavoidably today. You've already had an opportunity to hear who my colleagues are. We want to just give you perhaps a little bit more of a background. I am the education rep on the Allied Health Professions Federation. I have a background in workforce development from an educational perspective, and I'm past chair of RCSLT, Royal College of Speech and Language Therapists, and through that have sat on the Allied Health Professions Federation's board in the UK. I currently manage in my academic role a postgraduate course, Improving My Service module, which is very much dedicated to AHPs bringing to the table a workforce issue from the service user perspective and seeking to solve it. And therefore, it's with that experience of over 100 plus AHP postgraduate students through that I can say we are truly solution focused. We are seeking to be flexible and adaptable and making a difference to the healthcare of the population of Northern Ireland. Karen Middleton is CSP, Chartered Society of Physiotherapists. Their CEO at the moment is a physiotherapist, also by profession. She's had the opportunity to look at the other side of the table as the Chief AHP Advisor to the DH in England for 10 years. Andy McFarland is here representing Allied Health Professions Federation as both Karen and myself, but is also the College of Paramedics representative here, and is himself a practising paramedic. We won't rehearse the briefing paper because obviously you have it in front of you, but really we wanted just to flag that the Allied Health Professions Federation is a UK-wide federation comprising of the professional bodies of 13 AHP groups. In Northern Ireland, however, paramedics are not yet recognised as part of that AHP workforce in the DHSSPS, but from the Allied Health Professions Federation perspective, very clearly they are part of the AHP family. So that's where you might find a difference between 13 professions versus 12. The Allied health professionals in themselves have got a depth and a breadth in terms of qualifying. They are qualified to degree level. They have a strong foundation in the medical model quite clearly, but they also have a very, very strong value system around working in biopsychosocial, social models of care. And just to flag that we are both assess, diagnose, treat, and also discharge in our own right. We are autonomous practitioners. This flexibility and adaptability that is captured in the AHP workforce, both in the UK but specifically here in Northern Ireland, we are very, very keen to be positioned correctly in the various structures that can influence and bring about the change that's needed. And you can see from our briefing paper that we acknowledge very much that the contribution of HPs to the delivery of TYC has been recognised in terms of the plan, but we are seeking to be able to influence it practically. We are not finding it easy to influence for good at that level. You're aware as much as we are about the changing demographics of the population, which actually mean that when you're looking at the ageing and the complex needs that comes about from a variety of long-term conditions coming together, that what is making a difference to the quality of people's lives is podiatry, speech and language therapy, communication, swallowing, physical mobility, independent living, and health and well-being. All part of the remit and portfolio of AHP skills. We have an economic argument that we think, and you'll understand why we are persuaded by it, which is that in terms of AHPs, we're already trained at a level with a postgraduate structure that allows specialism, but we're actually 4 times cheaper to reach advanced practitioner level than a GP, and we actually get to that level quicker than, for example, a GP. And therefore, we're seeking to actually help do things differently, not to increase cost, but to actually see how can we shift, flexibility of thinking and workforce profiling. And very much that there is also some evolving roles that AHPs are taking on and building on skill sets which have had quite a lot of piloting, and we're very keen to see those translate into actual working practices rolled out quicker than they currently are. Thank you.
Okay, thank you. And just before opening up, just ask members to be mindful of their mobile phones, because broadcasting are unable to pick up a lot of the proper recording because there's phones interfering, so just be mindful of that. Thank you for that. Just maybe the way of direct questioning, I suppose, in terms of our work around workforce planning, we've heard now from a number of professional bodies, obviously, and you touched on it yourself in relation to the major challenges around, you know, an ageing workforce, an ageing population generally, and what that brings in terms of recruitment and retention, and often working conditions also. Are they issues for yourselves as well?
Yes, there is inconsistency very much between trusts and the workforce review or planning. It's really needed that each trust has an opportunity to engage properly with the AHPs to actually find out what are the local needs. We're finding that there is a very inconsistent approach to workforce.
So is that an inconsistency among trusts and how they
are reviewing their workforce and how they're planning? There appears to us to be no strategic workforce planning. There's a lot of promise, but in reality we are not seeing it happen, and where it's happening in pieces, it's too small and too localised to actually have an impact. Perhaps my colleagues might want to.
Yeah, I think the issue is around the word transformation in TYC. I mean, to get real transformation, there needs to be a more strategic approach to workforce planning, and the local differences and the local arrangements around workforce planning isn't, in our opinion, going to deliver this transformation that's really needed, something really quite different. So, thinking about primary care, for example, the workforce situation, the evidence that's been given by the Royal College of GPs, the BMA themselves, highlights the dire scenario around the number of GPs that are leaving primary care, the lack of doctors wanting to train as GPs. Yet we know that 20 to 30% of what any GP sees every day is musculoskeletal, so back pain, joint pain, etc. That 30% could be seen straight away by a physiotherapist and free up. We've calculated in the UK nearly 100 million appointments a year, that's UK-wide. So that's capacity freed up, but that's a more strategic approach to workforce planning. So looking at real transformation in how care is delivered. That strategic approach is about managing the demand on healthcare differently. And as I say, with the example from primary care, looking at a different way of supplying the workforce, so whether it's podiatric surgery and podiatrists providing surgery, which is of better value, better outcomes for patients, whether it's physio providing primary care services, paramedics, I'm sure Andy will talk about, but also in terms of managing the demand, the allied health professions take a much more holistic approach in terms of combining the medical model, yes, with surgery, in terms of independent prescribing that physio and podiatry has, but also combining it with the biopsychosocial model, so keeping people physically fit, keeping them well, keeping them at work, off benefit, maintaining their independence. It's all of those things that you get from taking a much more strategic approach to looking at the workforce supply completely differently. I don't know if there's examples.
Just in
from
terms of
Amy.
strategy, TYC often refers to, well, quite a lot refers to the implementation of TYC regarding the ambulance service, but it rarely mentions the clinicians. The paramedics and the College of Paramedics have not been engaged in any sort of strategic direction regarding TYC. In fact, as Rosalind said, we're the only country in the UK where we're not recognised as allied health professions, and we're pushing that forward locally with the department. But I just agree with my colleagues. There's so many things that we can do that we're not being allowed to do within our local scope of practice. For example, the advanced care paramedics, community paramedics, running minor injury units, going out to people's houses, doing a minor assessment and a wound closure would avoid an elderly person going to hospital. Lots of different ways we can be used, but we're still very much stuck in the transport model. Now that is changing locally, which is good. There has been some investment locally, and we are changing. We're leaving people at home. We're referring people to doctors. We're referring them to the pharmacy and to Falls team and diabetic nurses. But we need to be engaged in a strategic approach.
And you see, if it's not strategic or there is a need to be strategic, whose responsibility is it to do that strategic piece? Is it the department? Is it the board?
Department.
Well, I'm asking.
And I think that what we would say is that we, representing the professional bodies of the third largest clinical workforce, which is what AHPs are, really want to be part of that support and engagement in the strategic workforce planning. You know, we've got the data on our members, we've got the innovation, not only from across the UK, but from across the world, where we can share the best practice, share the evidence in order to speed up some of this innovation. Because I think the issue is that we're not looking at something that's going to happen in the future that we can start planning for and start, you know, taking our time with. This is happening now, and we have solutions now. If the professional bodies could be engaged.
But it's ad hoc and it's inconsistent.
Ad hoc, inconsistent, and the professional bodies are not involved at all. At the
Okay,
moment.
and just picking up on a point that you said there, because we've heard this from the unions as well, in relation to I think it was 20% of GP appointments for musculoskeletal conditions, and you
20 to 30.
20 to 30%. And I know it was one of the issues that the committee took issue with around the self-referral pilot for physiotherapy, which, you know, on the face of it made absolute sense in terms of transforming your care, and turned into a bit of a tug of war to actually get it operational. What figure did you put on? How many appointments would be reduced?
100 million
Right.
in the UK. So in Scotland, 86% of the population has access to self-referral, full self-referral. 14% of Scotland has partial self-referral. Wales at 63%, England dragging behind on 40%, but a real drive in England at the moment, because the calculation that's been done, for every 100,000 of the population, by introducing self-referral and doing nothing else, you save £25,000 for every 100,000.
Has there been a calculation for that for the north of Ireland in terms of GP appointments or the
Not
reduction?
specific
Right,
to
okay.
Northern Ireland, no,
Okay.
not to my knowledge.
Okay, thank you.
But that's
for that.
UK-wide.
Yeah.
Yeah, but Chair,
Yeah,
just
sure.
when you're on self-referral, I mean, we all know the disappointment that didn't happen, but I have it in my diary, and I don't know where we got it from, but it was somebody from the committee, that it was to be rolled out on the 25th of May, which was Monday past. Has it been done?
As far as I'm aware, the pilots have started, yes.
Oh, right, okay, that's
But
progress.
that's not rolled out. That's just the pilot. Well, I mean, the pilots have been done all over the UK. It's tested, it's proven. There really is no need to pilot it yet again.
But it has not been rolled out on Monday?
Well, I presume the pilot has started, but I don't.
Yeah.
That's just a pilot, not full rollout.
No, that's different then. We will watch this space then.
Okay. Rosie was next.
Okay, Cormac Carley, and thanks very much for the presentation. So the whole emphasis is from your presentation, it's on doing things differently. And could I just ask, are you aware if any new service models being developed by the board under TYC or being used by trusts that will require AHP staff to do things differently?
Okay. Yes, Rosaline. As I say, locally within the ambulance service, there has been some money put towards TYC, and there's what we call appropriate care pathways. So instead of just the normal transport model, which we've focused on, something wrong with you, we'll take you to hospital. We've started to assess, treat, and sometimes discharge at the home or at the Seeing Shopping Centre, wherever it is. There's different referral pathways for diabetics, falls patients, different categories of patients. That is happening. It's quite patchy at the moment, and I don't think any of it's province-wide, but it's very much trust-dependent, so we're very much linked with the trusts, whether they can accommodate our referral for the occupational therapist or the physiotherapist, etc.
Okay. And can I ask you, is there anything like different that AHPs have to offer in terms of, you know, the emergencies and the whole crises around A&E? Could AHPs offer something which isn't already available under trusts?
Yeah, well, a lot of our colleagues in England, as I say, with the advanced practitioner model, sometimes known as a community paramedic, they're actually running minor injury units. Some are based in a mobile model, which are just as we are at the moment, in a mobile, in a car, paramedic, and dealing with very low acuity calls. So maybe you have a minor injury or a minor illness, they'll go out and assess, treat, and if necessary, yes, they'll call for transport to hospital. However, if it's minor and they can deal with it, they'll deal with it and refer you to your GP in the morning, arm assist, falls team, diabetic team, whatever. So it's been proven, there's a lot of figures out there that has been proven to reduce hospital stays, which translates into a cash value.
Another example that I would give, I mean, one of the biggest reasons for people attending A&E is through falls, particularly in the over 65s. It's the major reason. And we've calculated that if you develop physiotherapy falls-led services in Northern Ireland alone, you'd save £8.2 million a year, saving over 70,000 falls. So never mind the saving in the money, the stress and anxiety that something like any of your relatives that fall admitted to hospital, and then the ongoing needs. And what we know is the evidence shows that most scenarios like that don't end up with the person going back home. They actually tend to go into care. So actually, if we could prevent these falls through physiotherapy falls-led clinics, then that would stop a lot of the demand into A&E, stop a lot of the expenditure that goes on keeping people in care, for example, after a fall, and would also free up a lot of GP time, because again, it's a demand on primary care that's unnecessary. We've calculated that for every £1 spent on physiotherapy falls-led clinics, you reap, your return on investment is £1.50. So I suppose the point that we're trying to make, that this is makes good clinical sense, it's good for patients, but it's also good for the taxpayer and the system. And that's what transformation is really about. It's doing things radically different, but we're only going to get the difference if you engage the people who can innovate in the actual planning. If you don't, then history tells us you just get the same old, and there's no transformation, it's just more of the same.
If I can just give an example, a patient I had yesterday fell in the street, an elderly lady. I assessed her, she had no injuries, but she told me that was her second fall in 2 weeks. And as Karen was saying, the more falls you have, the more likely you're more likely you are to be hospitalised and break a hip. So in the course of my assessment, I've advised her to go to her GP and have a falls referral through an OT or a physio. But during the course of the assessment, I took her pulse and found out that she had an irregular heartbeat. So I asked her, do you have atrial fibrillation, which is a heart condition? She wasn't aware of that. But again, that's another thing that she'll be telling her doctor, hopefully. But hopefully in the future there will be a system where we can actually refer that person to the doctor's notes directly, because we're very much depending on that old lady who might be forgetful or might have poor health care, self-care, to not tell her doctor. But if I can directly refer her to her GP, who now knows, oh, this is the second fall in 2 weeks, and now she has atrial fibrillation, the doctor can treat that condition with medication, probably avoiding a heart condition, avoiding a stroke.
At the moment, I think it's in Antrim Area Hospital. Physiotherapists are going in at the weekend to ED in order to support people who've got soft tissue injuries. So advising appropriately, in other words, that that person not only gets the best of physiotherapy assessment in ED, but also gets appropriate management so it doesn't become a chronic problem. So there are those pockets, if you like, of pilots that are taking place, but they're in pockets.
Okay, so do you think there's resistance to new ideas or new ways of doing things that is unhelpful?
Well, could I just, from my perspective, with looking at these 100 HP projects coming to the surface, and also from the HPF's argument, at the moment we don't have AHP's position strategically at the right level to ensure that those very good, innovative, new ways of working come to the surface. It seems disproportionately difficult for us to influence, and that would be at the department level. There is only one AHP advisor for 13, well 12 at the moment, but paramedics I'm sure we'll see the sense and bring them on board. But for those 12 professions, for one person to be seeking to advise that number, that's very difficult, and that's sitting under nursing. And so if you look even in the trusts, there is no model whereby AHP strategically are positioned sufficiently to allow those agents of change in those band 5, band 6, band 7 posts to make a change. So it's systemic. It's also being in the regional integrated care pathways that we're seeing ourselves as books, as HP input. We're not consistently sitting round the table. But it's not that we're not trying. We feel as a AHPF, we've been working very hard and very cooperatively to engage that, but it's slow work.
Okay, just one other question. Just can I ask, as part of the shift left under TYC, the department has told us that around 25 million has already been shifted from hospital services to community primary services in the areas of learning disability and mental health resettlements. Has that had any impact on the HP staff, to your knowledge?
We have no clarity regarding the dispersal of that money that's referred to above. We would actually seek assistance in determining where the funding has been allocated. We're aware of some recent workforce spans, but no detail on a regional basis. And that comes back to a more clear, open and transparent commissioning process to allow us to see what is happening at the moment. We're unaware where the money has been spent. We don't know the breakdown, we don't know who's benefited.
Right, okay. Thank you.
Okay, and Kieran?
Thank you, Chair. Thank you very much for your briefing paper and your presentation. And I'm fascinated with your responses to Rosie's question about what you can do to prevent or help ease the burden in our A&Es. It's unbelievable. What you have told this committee. Is there nobody listening? Is there nobody listening to what you have to offer and ask you to do it and provide it and overcome the problems that we're hearing so often about in accident emergencies?
Well, I think that's why we're trying to understand why it's such a compelling case. And, you know, I often describe it as a no-brainer, frankly. If it's in the interests of the person, the patients, the public, the taxpayer, the system, etc., why wouldn't you? I don't think any other industry would not take notice of this sort of information and data and experience from other parts of the country. And the conclusion we've come to is that we're just not represented where we need to be represented. So Ros has highlighted in terms of the AHP representation at the department, again, not at the top table. In trusts, in hospitals, again, AHP is not at the top table. So constantly you're pushing against the way we've always done things. If you look at Wales, for example, where they've appointed a director for AHPs on every board, and then they have the profession-specific advisors below, because one person can't possibly do it all for 12 professions and all the subspecialties. So there is something about a systemic need to look at who is represented where, because if it's only ever about the medical and nursing workforce, the likelihood is you will only ever get medical and nursing solutions to the problem. And I come back to that word transformation. It's got to be something different. Otherwise, you know, we'll be here in 2 years' time still talking about these problems.
Yeah. Thanks very much. I'm sure, you know, somebody's listening to what you've just been saying, and some action will be taken, and surely the report that will come from this inquiry will point that out. I mean, we've heard it before from other people presenting to us, but just on that, we know that neither you nor your other representatives bodies are for AHPs are represented on the Regional Workforce Planning Group. I mean, that's one of the things you're only after saying to us. To what extent do you think the views of your workforce are being taken into account by the department in terms of developing the overall approach to workforce planning? Probably the answer is no.
Well, I mean, it's not evident in the sense that these solutions aren't being rolled out in the way they should. It's not only the department, though, there's also the commissioners that need to be paying attention to this in terms of commissioning different service models for the future. But again, if you've only got one person at the department doing this work and trying to make the case, then it's very hard for her too. So I think it really is about how us as professional bodies can help in terms of advising, supporting this transformation and being part of and engaged in an integral way, not just as sort of an outsider, as a sort of stakeholder to the Regional Workforce Planning Group, but actually being part of it, I think may well bring about some of this change, because it's irrefutable evidence. I mean, it's, yeah.
A couple of others. Is there any retraining of AHP staff required in order to meet the shift left requirement of moving more services into the community?
No.
Right. Do you think that there are currently enough staff within AHP workforce to be able to deliver the new services model envisaged in Transforming Your Care?
That brings us, I think, to an example of the nub of this question. We're unsure of the staffing levels because there has been no review since 2005. We've also not been part of the information gathering process, so therefore we can't actually even endorse figures coming from trusts. If new staff have been employed, we don't know where they are. So we need to be very careful when we discuss have we got the right numbers within the workforce, because we really don't know. Also, we know that the figures should reflect staff in post and not actually posts that are holding or where vacancies exist or they've not been filled. I think you've picked up already from what we've been saying today that we think the focus should not be on the number. It should actually be on the collective. It should be on the profiling of that workforce. It should be on the it's almost like a matrix approach, isn't it? You know, you've already moved some way towards condition-specific workforce profiling, and it's that along with what within the uni professionals, what is needed, uni professional groups. You know, for example, looking at the demographics within radiography, being able to predict and plan for those new ways of working. So we would we at the moment cannot answer that question, and that I think is indicative
Yeah.
of the
Thank you very
challenge.
much. Thank you very much for your presentation, and I wish you every success. I hope that the powers that be are listening to this and will take action sooner rather than later. Thank you for us all. Thanks, Chair.
Okay, thank you, Kieran. Michael?
Thanks, Chair, and thanks for the presentation. I have to say it's revealing and not dissimilar to the sort of presentations we've been having from other groups within the workforce. In terms of strategic planning, and obviously you're saying you can offer solutions and so on, is there absolutely no contact at all from Department in terms of their workforce? Because they have a group set up for workforce planning. They're not talking to you at all. Is that basically...
From our professional bodies,
Not-
view,
yeah.
Michael, we're not even recognised, so I mean,
But you're not sort of recognised through, say, Unison or through trade unions or something like that?
well, they're unions, that's a trade body.
Yes.
We're the professional body.
In terms of your professional body, you're not getting in any other way. This is your professional body, and you're not being talked to.
We're not being recognised as allied
Yes.
health professions in Northern Ireland, so we are not party to any strategic document.
Right.
But even if you were, like we are,
Even if we were.
we're not. Not as professional bodies now.
Do you not have representation on the commissioning groups? Right. That was an oversight.
The employers may, but
Yeah.
the professional bodies don't.
The professional body, because there's pharmacists, and as I recollection, there was an allied health professional as well.
We need to be clear here.
Yeah.
I'm talking about the professional body isn't recognised. So there may well be
Yep.
clinicians, and if it's one AHP, I mean, again, they're representing 12 professions and all the sub-specialties. We're specifically seeking to engage and involve the professional bodies because, as I say, we have got that UK-wide, much broader international perspective on innovative
Yeah.
solutions and a lot of the data.
Yeah. Just as the commissioning group here informs the commissioning plans
Yeah.
as they go forward, and there should be a health professional as well as there's a pharmacist, a nurse, doctors and so on. So you reckon you are represented on those?
There may be.
You should be.
There may be professionals on those bodies,
Yeah.
not the professional body as a whole.
Yeah, but they're representing their professional occupation, shall we say. Anyhow,
But it might be as a collective, so an AHP
Yeah.
representative, you know, in terms of nursing or medicine, it's of the one profession, whereas this is 12 different
Yes.
professions, totally different. I mean, you're
a
ranging from
commissioning
the
group
arts
is 12
therapists.
people. I think it's 12,
Yeah.
12 or 14, so you couldn't have all 12.
No, maybe not all 12, but there should be at least some way of feeding
Okay.
in from a professional
from the
specific basis.
You don't have specific, you give us the total there for the UK total. We don't have, and that's recoverable, we can find the information many people were talking about in Northern Ireland. What's your rough breakdown, do you reckon, between secondary care and, say, community care, primary care, as far as your professions are concerned? Would you have any idea?
No.
And would you have any idea where you would be or where you think you would be once we move this transforming your care? You're not involved in any of that planning as well?
As professional bodies, no.
Yeah. Okay, that is actually, it's very disappointing that you're not actually, I can see why you're frustrated in terms of that. I think that's the key thing you have to be doing, and you have to be in the middle of that. Okay, Chair, that's fine, thanks.
Thank you, Michael. And Alex, next.
Yeah, hi. I understand how you feel about not getting listened to, because I was the Assembly Private Secretary. And whenever I talked to department officials, when they had an idea, they sort of went away and then they came back and they sort of poo-pooed whatever you had a good idea, so sort of understand that a wee bit. So there you go.
And what's your top tips?
I don't have any. Can you give us an idea of the gender mix in the AHP workforce? And also, is part-time working an issue in the AHP workforce? And the last wee bit is, do you think workforce planning at a department level is taking into account the gender mix of staffing and the social workforce patterns?
The gender mix is predominantly female across the AHP professions. Some of the professions have more of a male-female split than others.
Yes.
So speech and language therapy would be 99% female. Physiotherapists would differ, so would radiography.
Yeah, I think paramedics, last figures I saw locally were probably about 25 to 30% female. And for the part-time working issue, I think it's not a big issue, so I think it's fairly well accommodated here.
The what we're probably more interested in is the 7-day working, because a lot of the work that AHPs do, I'm thinking particularly of, say, speech and language therapists assessing swallowing within the acute hospitals, that very often that swallowing assessment is the difference between someone being able to leave hospital or not, and therefore 7-day working for some of our AHP colleagues working in those sectors will help make a difference, I think, in terms of throughput. So as a collective, I just wanted to say that the AHPF are very supportive of the ethos of a flexible workforce and is supportive of predominantly, with a female gender mix, greater accessibility to work. But we're also very aware that 7-day working is very helpful with appropriate resource, obviously. It does need resourced as that. Paramedics are an optimal example of 24/7
Yeah, and we
anyway.
work 24/7, so it would be nice to have other professionals who we can refer our patients to also be working 24/7,
Pilots have taken place.
or at least 7 day a week.
Yeah, pilots have taken place with OTs and physios working for 7 days. But
How did
we're
that go?
actually surprisingly well.
Right, okay.
We can, I think with appropriate resource, what it does is it actually prevents that Monday where you've got a massive block, and then on the Friday the massive rush, and you're also being able to provide the right support in such a timely way that is very very helpful to families as well as to the patient.
I think the difference between the allied health professions as a group, and I think we do need to bear in mind that there is diversity within the group, hugely in terms of what they do. But the general ethos is one of supporting independence and maximising anybody's potential to work, to function, to get home, to do whatever they want to do. We don't create dependency like the medical model can. And I think that relates to why often we're so invisible, because actually what we're about, our success is the more independent the person is and isn't relying on us as clinicians. And when you think about what happens over a weekend or over an evening, for example, in terms of, my own clinical practice, I can remember the difference between leaving an orthopaedic patient on a Friday and then seeing them again on the Monday, the deterioration that went on, when what that deterioration was about was not only pain and discomfort for the person, but you're again elongating the amount of time that person's in hospital when they could be at home, independent and starting to get back to work, etc., etc. So I think the other part of the transformation that we're talking about is not just about a different sort of workforce, different service models. It's a different way of thinking about healthcare, about really giving people, empowering people to take control of their own health and well-being, and the focus on independence and work, and not dependence on a healthcare system. Otherwise, the NHS is just constantly picking up the pieces. So I think it's about a shift in thinking about healthcare. And I think in reading TYC, that's a theme that comes through. You know, this care closer to home. It's sort of demedicalising our health and well-being, and I think that's where AHPs, particularly over a 7-day period, have a real role to play.
Okay, thank you.
Okay, thank you, Alec. Pam?
Yep, thank you, Chair, and thank you for your presentation. You've really preempted my question. I'm going to ask it again anyway, just for clarity, and it was around well, obviously this review is looking at the desirability of 7-day working. and Rosalind, you've already spoken on that. So I wanted to ask you, was it an issue for allied health professionals? Obviously, it's not an issue for you as such, but there's a knock-on effect, and you would need other people to work in that fashion as well. Have you any ideas as to how that would work, or how those issues could be addressed?
From the perspective of the AHPF, clearly, and nobody in their right mind would expect that you would have the same workforce moving from 5 days to 7 days. So it comes with that caveat, doesn't it, of appropriate resourcing. I think what we find invigorating, actually, is that despite the pressures and the stress of being in the front, we talk about the front line, but it's really tough, as we know, there is still an absolute willingness to embrace a change, a fundamental change in terms of a pattern of working, because it is making a difference. So I think that flexibility and that commitment to be innovative because it makes a difference to the person is percolating up through our memberships across our professional bodies, and which is why I think we can say with confidence from our Allied Health Professions Federation's position, we're fully supportive of it because it makes sense.
However, you can't provide a 5-day service over 7 days for the same amount of money or the same service. It's got to be different in some way. But I think the savings would be reaped further down the line.
Okay, thank you.
Okay, thank you, Pam. And Joanne?
Thank you, Chair. Can I thank you for your presentation? It was certainly very frank and honest. My point, suppose, would be, my question would be, one of the terms of reference for the review is to examine the extent to which workforce planning is taken into account of recruitment issues for particular geographical areas. And I know, Rosalind, you said at the start, I noted down, you refer to then consistency between trusts, and the need to engage properly and locally. So obviously, workforce planning in geographical areas is crucial. Is this an issue for AHP? And if so, if it is an issue, how would you propose to address it?
At the moment, as we've said, there is the one, and it's a seconded post, this seconded lead officer post, advising the department, overseeing these 12/13 professions. So in terms of the HPF, knowing of the recruitment issues for geographical areas, that is very difficult for us to know about. And the reasons for it come back to the fact that we've not got an appropriately positioned and appropriately resourced department level advisory team. Is it that the very fact that AHP lead post is not permanent speaks volumes. There is a potential crisis if that person is on leave or if they're on holidays. I don't know of any other significant part of the workforce that does not have the capacity for, at the department level, advisory issues to be picked up. But this is now 12 professions if that one person happens to be on leave or is unable to work. And therefore that inconsistency in support between the groups, between medics, between nurses, between AHPs, is very real, and it is damaging our ability to transform how we deliver care.
Essentially, if anything happens to that person, it falls apart?
It does at the level of the department, absolutely. And then when you look in terms of trusts, within each of the trusts, where the AHP voice is strategically positioned differs, so there is no one model that is consistent across. there's anomalies in that not all Trust AHP representatives represent all AHP groups. So not all 12 may be represented within trusts. The South Eastern Trust, for various reasons, has been identified by the AHPF as a good structure in that there is an AHP lead who is able to give appropriate evidence on waiting lists, is able to articulate targets and targets being met or not, looking at budget and delivering across time
How do you then
frames.
replicate that across?
And that's certainly, we're interested in the Northern Trust in that it's restructuring at the present. So at the moment they're talking about putting AHPs onto the nursing lead. We would clearly, as an AHPF, be seeking to influence that they're on a par. So it's about getting that AHP lead role positioned in each of the
I note your
trusts at the
comment,
right
is it
level.
seeking to influence?
Yes.
How realistic is that going to be, seeking to influence? How do you make it happen?
Well, we are here today. We are pulling together the resources of our 12 professional bodies to work together and to seek to campaign together and appropriately. We are working through our networks, through our special interest groups. We are working across condition-specific groups. But I have to say, any leverage at any level, anywhere, anyhow, would be greatly appreciated.
There certainly has to be the willingness from the Trust to make it happen.
And again, we have a responsibility as professional bodies for ensuring that the very positive can-do examples are
Replicated.
promulgated. Yeah.
Okay. Finally then, again, you talk about the need for a cultural shift of language when referring to health and social care. So do you feel that given the current perceptions, it will take a long time to achieve that shift? And where do you see it starting? Do you see it starting from top of the health service, or do you see it being patient-led upwards? Because certainly, you know, this joined-up approach, and if patients have very, very good, you know, they're recommending or they know how it works for them, should it be, is that going to take a long time if it's patient-led? Where do you see that you feel this should happen, patient-led or health board?
If I address that first and then hand over to my colleagues, I think that where patients have got very strong charities articulating their voice and lobbying for them, the Stroke Association would be a good example of that, then I think that becomes a very powerful force for change in partnership. Where you've got someone, in my field as a speech and language therapist, where someone has not got their voice, where they are not empowered, where they do not appreciate how much better it could be, then at an individual level, it's impossible to see how change can be brought about. So I think through the partnership with, like the Long-Term Conditions Alliance, for example, lobbying together to make that patient voice very vocal.
Certainly people power is very, very powerful.
It is. But it's in combination, isn't it, with the strategic planners, with the commissioners, with the PHA, with the trusts.
I think that the department has to be a voice for us as well to promote what we can do.
I think the people power is really powerful, except that often the people that these professions are seeing over a period of time are the most marginalised in society anyway, without a voice, without the ability to get to a place to speak, etc., etc. So every now and then you get a very vocal, articulate person in the public eye. For example, Andrew Marr, following his stroke, has done a huge amount in terms of expressing what the allied health professionals, physiotherapy in particular, have done for him. But I think if you want culture change, that culture change comes about as a result of the very top changing. And people forget, I think, how important language is in terms of culture change. And simply, constantly saying doctors and nurses, doctors and nurses, doctors and nurses will just reinforce that message that healthcare is only about doctors and nurses. And we were talking earlier about experience in Australia, where ministers talk about doctors, nurses and allied health professionals. The nearest we've ever got to in the UK is And the Unsung Heroes, which says volumes, really. So I think...
Is that the paramedics?
I'd like to brag.
But there is something about almost creating an expectation from the top that this group of professionals, I mean, the third largest clinical workforce would be involved, and I think that that does need to come from the top.
Okay, thank you. Thanks.
You're welcome.
Okay, George had indicated, yeah.
Thank you, Chair. Just following on from Pam's question, it's more an observation, comment, and listened to the Queen's speech today and observed that the new government proposing 7-day working for the health service.
I was delighted to hear that, on the radio, and I thought that echoed very much our thoughts in preparing for
Yes,
today.
you've been to, you've been saying.
Yeah, thank you.
So at least the Queen's listening to you.
Well, I said it's got to start from the top.
Okay, well, I mean, thank you all. I think it's been very useful. There's a clear pattern, I think, as we conduct this review, and I know as well as the piece around workforce planning itself and the need for the Federation, the professional body, to be able to influence and participate in the process. There's also the issue, I think, around the system itself, that cultural shift that you referred to, and you know that I think it's bringing to the fore roles and remits. I think it's bringing to the fore issues around commissioning as well as we go forward. So that has been extremely useful for us today, so thank you for taking the time, and we'll certainly be reflecting on the evidence that you've given us. Thank you.
Thank you. We very much appreciated your time. Thank you.
Okay, members, moving on to item 5, which is the Forward Work Programme, which is page 60 of your meeting folder. Just asking members to note at this point. Item 6, Matters Arising, and there are 2 items under Matters Arising, which are page 63 of your meeting folder. Page 64 is a response from the Minister in relation to the implementation of the recommendations contained in the Marshall report. I'm seeking agreement to forward the response to the Children's Commissioner who had raised these issues. Agreement. And page 66 is a summary of the discussions and proposed actions from the informal committee stakeholder event which took place last week. Asking members of their content to action as outlined. I think it's a fairly detailed
Chair,
response.
just one question. I think if I can remember right, Strangford Bay, the respite facility, I think that asked for perhaps yourself or a member of the committee to visit. Has it been your intention? I know it's a fair stretch from Derry to Portaferry, but is there anyone else that's maybe near hand that could be nominated? I think, have we a new deputy chair who lives not that far away?
You're determined to get your next post with Board Fulcha and get people to visit Portaferry at every opportunity. But I mean, happy to look at it if that was a request from the group. We'll certainly look at it and bring it back. I can't speak on behalf of the deputy chair, but we can look at it and come back to you. Is that okay?
Yeah, sure. That's
Okay.
fine.
Item 7 is correspondence, and there are 19 items at page 70. Just want to draw your attention to several of them. Page 72, firstly, is correspondence from the Minister providing a copy of the final adult safeguarding policy and requesting the committee's views on it by today. Just want to remind members that last month we had considered the summary of responses to the consultation and noted that in terms of the proposal for adult safeguarding legislation, which if members remember, the Older Persons Commissioner had made a very robust case around the need for definition of abuse and actual legislation to protect older people. The responses coming in the consultation had said there wasn't a consensus of views, and so the final policy does not include adult safeguarding legislation. Just again reminding members that we had written to the department to ask on the back of that what were the key issues that were raised in terms of the possibility of legislation. If members also reflect on there was an assembly debate on this and which stakeholders actually expressed a view on the matter. We haven't received a response despite reminders to the department, so I'm seeking agreement, members, that we write the department to express a disappointment because we haven't had that response, and the expectation that the committee could provide views without the requested information being provided. We're being asked to provide a view and we haven't been given the response that we sought. So I'm seeking that agreement that we would write back expressing that disappointment.
Agreed.
Page 236 is correspondence from John McAllister, MLA, advising us that he intends to bring forward an amendment to the forthcoming Health Miscellaneous Bill to ban smoking in cars where under 18s are present. Just to inform members that this matter will be dealt with, obviously, when the bill gets to committee stage. Also, page 250 and 254 are correspondence from Nexus and ADD regarding the infrastructure support programme. We have, as referenced earlier, received a response just today, so I'm seeking agreement that we would share that response from the department, which was tabled today, in relation to the core funding for the community and voluntary sector. Members agreed?
Agreed.
And 255 is correspondence from BMA requesting to meet the committee. I'm seeking agreement to invite BMA to the next stakeholder event. 256 is correspondence from Kinship Care regarding the recent informal stakeholder event. A copy of the invite that issued to the organisation is at page 259. I'm seeking agreement, members, that we write back to Kinship Care outlining the content of the invite that was issued.
Agreed.
Agreed.
Chair, I mean, I have to say that I would refute the allegations that was made, it's contained in that letter. In no way was anyone, certainly at our table, and I'm sure at other tables, were they humiliated or in any way. They were treated with utmost dignity. And I don't think we should waste any more time on it, unfortunately, that we will treat everyone with equality.
Chair, I would concur with everything that Kieran said.
Very much so, yeah.
Okay, thank you, but I think we should, because, I mean, my sense of this is that every organisation that came to the event was very clear in the remit and the 15-minute timescale and all of that. So I think we should go back and clarify that with the group, and that would be the
It
end
may be
of it.
possible, Chair, I agree with you what you're saying. Maybe Kinship Care, I don't think made their case as well as maybe they expected to or wanted to, you know, and because we had some other groups, we had the suicide group, for example, who were very, very powerful. Kinship Care basically wasn't able to tell us what the unmet need was, and that was the question we asked them. So
Okay.
I'm happy to write back to them. I wouldn't say that we shouldn't listen to them again, but I think they need to read their invite, but they understand that.
Okay, thank you for that.
Just
Yes,
to
Kieran.
finish, I mean, I had an email, maybe others had, from Parenting Northern Ireland, expressing their deep appreciation for the way they were treated and handled, and look forward to coming back again, you know, so.
I think it is important to say that I had 3 different organisations contact me as well to thank us for
Yeah.
the time, and in fact the outcome from it was probably more than they expected, so I think it's important to point that out as
Yes,
well.
Chair, just to concur with Kieran, that most of them we had were very, very positive and a great engagement, and it's unfortunate then not to receive that letter.
Okay, members, 263 is correspondence from an individual regarding the care of a relative received in the Belfast Trust. Again, members, as process, I'm seeking agreement to forward the individual's contact details for 6 constituency MLAs.
Great.
And page 265 is correspondence from an individual highlighting the potential benefits of a patient appointment reminder service for GP appointments. I'm seeking agreement because I think this is a wider policy issue, to write to the department for clarification on whether consideration has been given to the introduction of such a system and what plans there are, if any, to reduce the number of did not attends and the associated financial costs. Are members agreed with that?
Agreed.
Okay.
And seeking agreement then to note the remaining correspondence unless members have any comments to make. Item 8 is any other business. Do members have any other business?
Just one, Chair, and that is to put on record our appreciation. We all got letters from the Health Minister during the week about the reintroduction of the Independent Living Fund, which is going to be administered jointly with the Scottish Independent Living Fund. And I would like to put on record my thanks and gratitude to two people in particular, Nicky and Charles Rainey from Carrickfergus, who campaigned for over 2 years for this outcome. And they brought the community with them, and it has been a very good outcome for everyone concerned.
Okay, well, I appreciate that, thank you. And item 9 then is date, time and place of next meeting, which is Wednesday the 3rd of June at 2 o'clock in the Senate chamber. Thank you.
29. This is the Northern Ireland